Good morning, everyone. Welcome to Thyroid Multidisciplinary Seminars. We welcome you to the new year here and really have just a spectacular program set up this morning to help clinicians primarily to understand what is in the mind of their pathologist and what questions they should be asking. And we do have a world-class, and I say that really unabashedly, a world-class group of thyroid pathologists. And we have a multidisciplinary world-class group of psychotherapists to help me to probe the minds of these pathologists. And so in order to get this started, I think the easiest thing would be for us to give just a really one-sentence introduction. I'll start as you appear on my panel. Dr. Shaha.
Yeah, I'm Ashok Shaha. I'm one of the head and neck surgeon and endocrine surgeon at Sloan Kettering. I have an opportunity to work almost more than 25 years, both with Mike Tuttle and Rani Hussain, from whom we have learned a lot and developed a state-of-the-art thyroid cancer center.
Great. That's more than one sentence. So, Mike, you don't get to introduce yourself. In fact, you don't need an introduction. Eyal.
Hi, I'm Eyal Robenshtok. I'm an endocrinologist and thyroid cancer specialist from Israel.
Dr. Wenig.
Bruce Wenig, head and neck and endocrine pathologist at the Moffitt Cancer Center in Tampa, but really a Bronx boy, displaced to Florida.
Okay. Ronnie?
I'm a head and neck pathologist at Memorial Sloan Kettering Cancer Center in New York.
Great. And Zubair?
Zubair Baloch, pathologist at University of Pennsylvania in Philadelphia.
Great. Peter?
My name is Peter Sadow. I'm a head and neck and endocrine pathologist at Massachusetts General Hospital in Boston.
Awesome. Margie?
Hi, Margaret Brandwein-Weber. I'm a head and neck pathologist. I'm chief of pathology at Mount Sinai West, and I'm a distinguished partner in crime with Mark Urken.
Wow. Okay. And finally, Yuri.
Yuri Nikiforov, thyroid pathologist and molecular pathologist, University of Pittsburgh, Pennsylvania.
Great. Terrific. Well, thanks, everyone. And thank all our panelists for joining us this morning. And I really encourage all of our listeners to send in their questions. We'll do our best to get to those before the end of the hour. I think it's really critical that we kind of start off with an understanding of the relationship between clinicians and their pathologists in order to underscore some of the critical nuances that relate to thyroid pathology and therefore relate to proper management of thyroid disease. And I think one of the things that might be helpful, I'm going to err on the side of gosh, I don't know what the right word is, but without being derogatory, all of you are not in the early stage of your career, except for Tuttle. And I think my first question really relates to is how have your interpretations of thyroid disease really changed with experience and the wisdom associated with seeing these diseases over and over again? And so, Peter, let me start with you. Why don't you lead off here?
Well, it's kind of been amazing for me to see how things have changed and yet stayed the same in terms of particular descriptions. I think the thing that's changed most for me over the years has been Yuri. Since Yuri arrived in this country, my life has changed. But I think the reason is particularly because molecular genetics, which really, this is the reason I throw at Yuri, but molecular genetics has really altered the way we practice pathology, particularly thyroid pathology. So even though the view of these entities under the microscope hasn't changed particularly, our understanding of the molecular biology and the molecular genetics of these tumors has changed the way we look at them under the microscope, and has actually provided us the gentle reassurance that a pediatrician provides the parents of children coming to the clinic, that these molecular changes give us the comfort to actually call them what we know we want to call them, the tumors. So it's been really, really helpful to me, and I've seen a massive change even in the last, I would say, 2 to 3 years. So it's really been a big deal.
Great, terrific. Zubair, how has experience changed your interpretation here?
I think, as Peter said, the histology is the same, but I think what I have learned is that pathology is just one piece of the puzzle of the whole thing. And what I have learned is more of a wholesome approach to really diagnosis, and you have to take everything in account. So, talking to your clinician, looking at your own experience and others, how these tumors behave. So I'm very gung-ho calling something malignant that before I thought, oh, this looks bad because I'm looking at one of those features. But I think it's bringing in everything, like, the preoperative cytology, and then looking at the lesion and having a conversation before you just say, okay, you know what, this is what it is, next case. So I actually feel that I've become more wimpier in my diagnosis. I take a step back and think about the whole case. And sometimes the younger people always say, oh, you're taking too much time than the other ones. And I go like, well, yeah, but there's more to look at and more to think about. So I have become more and more cautious, I will say, over the years.
Dr. Brandwein, you've talked about a feeling of being unsettled, and when you're looking under the microscope, and when you feel unsettled, it makes me feel unsettled to be looking at you being unsettled. Why don't you tell us a little bit about that?
Sure. So, your question can be interpreted in 2 ways. One is all of the enormous advances that we've seen over our careers in thyroid pathology. And the other one is how have we ourselves matured as pathologists? And I realized somewhere along the line, and maybe I'm pushed to be able to verbalize this as a mentor to my fellows, is that, there's that little inner voice, the little man that I used to joke about, but there's really this inner voice of, is everything okay? What bothers you? As it refers to this particular case, So I believe that the beyond our sort of training and visual intelligence, et cetera, there becomes this sixth sense or emotional sense about how a particular case makes you feel and what's unsettled about it. And so I also tend to be, I think, a little wimpy, a little cautious, because I've always got the patient on the other side of the microscope, so to speak. And so I may do things that might to the younger generation appear excessive or take time, like levels, et cetera, but it's more, I'm responding to that little inner voice to make sure that that inner voice becomes kind of settled when it comes to a case.
Great. Dr. Wenig, so, we, all of us on the clinical side here have the extreme luxury of working with expert pathologists day in and day out. For the people who are in the community who may not have that experience, talk to me a little bit about what that relationship should be. How should clinicians be questioning interpretations? What's a healthy relationship between a clinician who's at the interface with a patient and their pathologist who's giving them the answer that is going to follow that patient through from start of their journey to survivorship?
Well, I don't think there's a right or wrong answer to that question. I think the comfort level and interaction that has developed over time between any physician, clinician, and pathologist is key, whether it's in a university setting or in a community setting. And I think endocrinologists and surgeons need to rely on the pathologist's acumen. And when they don't feel comfortable because they don't see enough thyroids in a given case, to have the case sent to an expert. Having said that, if you look at the literature, the experts can't agree with each other on a wide variety of diagnoses. So just because it goes to expert X doesn't mean that expert is correct. And if it goes to another expert, and we had a similar case like that in New York, I don't know if you recall, there was a endocrinologist who felt uncomfortable with an atypical cytology diagnosis. The case was you resected it. Somebody at Beth Israel called it benign. Because of atypical, the endocrinologist forced a consult. The consult went to one of the more aggressive diagnostic thyroid pathologists, came back papillary carcinoma. You asked me to send it to Dr. Ozai, who was alive at the time, and Dr. Ozai called it benign. So I think, we need to understand that the experts don't always get it right or agree with one another. Going back to your question, it's really a comfort level of the pathologist who's viewing the thyroid and the relationship between the clinician and the pathologist, whether it's at a community hospital or a university hospital. I just want to go back to your very first question, and I want to add to what Peter and Zubair and Margie said. Molecular diagnostics has become a key component in diagnoses. I've always been a conservative thyroid diagnostician. When I can be benign, I will be benign. And so we need to understand that not every molecular change correlates to malignancy. So we need to be aware that, the molecular is important, but it also needs to be correlated to the histology. So if you have a TERT mutation and there's no invasion and you put that whole thyroid lesion through, it's still benign, even has an aggressive molecular finding. So, I think we need to be tempered in terms of how we view and not push a diagnosis because it has this molecular change. And in the past, immuno was supposed to be the key component to make a diagnosis of papillary, and that has not proven to be true. So I think everything starts with histology and correlated with the clinical, but understanding how the molecular does or does not impact on that. I know I digressed from your question, but I just wanted to add that.
Yeah, sure. So Yuri, you're the guy that has changed how these other panelists have thought. Maybe you can just weigh in on experience and wisdom over time. How has that changed your practice of interpreting thyroid disease?
Well, first of all, I want to say I'm not the one, and not even, person who mostly changed the field. There is a large group of molecular people who've done it. But anyway, yes, what I want to say, starting from also your kind of a first question, what was the biggest change to me over the course of my career? For me, it was a realization that everything in oncology and in thyroid tumor pathology is not binary. However way we wanted to believe it, many years ago it was benign malignant, period. Benign malignant. It was convenient for everyone. It was convenient for clinicians. Either you get benign diagnosis, or you get malignant diagnosis. What came what I came to realization, and this is all science over the last 20 years tells us this, that it's not binary. That cancer, follicular carcinoma doesn't develop as follicular carcinoma when it is 1 millimeter. It is not. Have anyone seen 3 millimeter follicular carcinoma? No. Why? Because they don't exist. Because they grow as adenoma, and then when they transform to carcinoma, then they invade and become cancer. And we all have been for the last 30 or 50 years talking about benign, where these tumors were. They didn't exist. This borderline tumor, yeah, they existed. We as pathologists were forced to call them either benign or malignant. And now we have to start change the mentality and realize that there are some tumors that are going from benign to malignant. They were somewhere in between. And these tumors are most difficult to diagnose by microscopically, because really tumor has features that are borderline. And with respect to treatments, the same. I'm sure that life was much easier for you before. It was benign or malignant. Now it's NIFT-P. Now it's atypical adenoma. I saw Peter's recent diagnosis, atypical adenoma. So what to do with it? But we have to accept That this is not people who just want to come and just invent something. This is how biology works. And understanding of this continuum, and continuum everywhere. Look at Mike Tuttle and continuum of risk. We have to accept that this exists. It makes our life more difficult, but it's more closely recapitulates the biological, the clinical course of the disease. So I'm going to finish, just say also what personally for me, how I changed in light of this. I, believe it or not, became less confident. When I was young, it was benign, malignant. Now I see, now I accept any possibilities. I accept that it's much more complicated, that there is another level of complexity. I do try to make a confident diagnosis, but I go through a lot of unconfident thoughts before I arrive to the confident diagnosis.
Great, terrific. So I know that Ashok and Mike have breakfast, lunch, and dinner with Ronnie 7 days a week. Tell me a little bit about your relationship with your pathologist. How would you describe that, and how close of a relationship is that?
Well, maybe I'll start because, as a clinician, I have a very good relation. I tell you one thing, the pathologist does make a big difference. And the confidence you develop with them, being able to reach out and asking the pathologist, can I have another opinion from your team, or can I send them to somewhere else? I think that understanding of the pathologist is very important, because you have to realize I'm not dealing with the pathologist or endocrinologist alone. I'm dealing with the patient who wants all the answers in the world. And one of the things I always tell them, even before doing the needle biopsy or the pathology, the difference between benign and malignant in thyroid is not black and white. It's a white and gray. Somebody will say it is gray, somebody will say it is white. And I think they understand right away. And I tell them one more thing. The difference between white and gray is not much, and that's the same outcome difference. Whether you have a low-grade cancer or no cancer, the outcome is the same. Our relations have changed quite a bit. I think Mark, 25 years back, before Mike joined us, it was me and myself. We believed very strongly in lobectomy, and we continued that because we were the people monitoring the patient. Now they are monitored by endocrinologists, outside physicians, and we need to understand that there is a difference of opinion. We can't be as stubborn as we used to be. And I think we have changed quite a bit. I just want to summarize one thing. I think Mike has written a paper on this. It's the thyroid is like a chair. There are 4 legs, and those legs have to be strong. And those legs are surgeon, endocrinologist, the pathologist, and the last one, which is very important, the patient. And if these 4 legs are not strong, there is one broken leg, it's going to be a problem managing that patient. You can't sit on that chair. I think that's the bottom line.
Great, terrific. So I'm going to move on to another topic here. And Peter, I've actually listened to you talk about this in the past, and that is that one of the factors that goes through your mind before you put pen to paper is whether or not you think another pathologist is going to be reviewing a case. And talk to me a little bit from a clinician's perspective, how we need to understand that dynamic and how that's affecting what you actually put in that final report.
Well, you have to keep in mind the audience is reading the report, because, if you start thinking about it like parents who send their kids to summer camp, where the camps start posting pictures of the kids during the day and the parents have a link and they keep hitting refresh so they can see the pictures of their kid come up. It's the same thing that happens with patients who have access to a patient gateway and they're waiting for results of a biopsy or a surgery. They're looking for the results. So the audience is the clinical person who's done the surgery. The audience is the patient. And so we have to keep in mind when we're writing reports, who's reading them and how they're going to interpret the results. So, this panel is an easy group of people. I'm actually very comfortable with everybody here seeing any of my cases, because if there's any difference in opinion, it's a nuance. and we all understand that nuance. So I'm certainly very capable of comfortable with that. But you do have to think about what you're writing, and actually what Yuri said is striking home. There are certain diagnoses that are now available in the WHO. These well-differentiated tumors and follicular tumors of uncertain malignant potential, diagnoses that I never would have even considered using because of being a cowboy. But at this point in time, I'm using them. I'm awkwardly using them. I'm introducing them into my practice because there is absolutely a spectrum of disease. And when things borderline, I'm not going to say it's malignant or benign, much to the dismay of some of my colleagues. But I'm going to just be honest about it. You have to just be honest about what you're seeing. And I actually will describe the reason I'm having emotional consternation about any particular case. And that's for my clinical colleagues, but it's also for my clinical colleagues to be able to have that discussion with the patient in terms of what are the next steps clinically to take.
Ronnie, can you just comment on that? If you think a case is going to get sent out for further review, does that affect what you actually describe and how you describe it?
No, not really. I mean, I'll just say my opinion. I just want to answer, if you let me, the initial question you asked regarding the change. It changed a lot. Just to give you an example, so I was taught when I'm facing a thyroid tumor to try to subtype it. Is this what variant of papillary carcinoma? But what we learned throughout the years, due to the many clinical pathology correlations that have been done in the last 30 years, the clinical molecular correlation, the very good correlation between molecular and histopathology, the microstaging is by far more important than really subtyping of tumor. At the end of the day, what really will guide Mike Tuttle are grade, vascular invasion, and other, of course, gross extrathyroid extension and things like that. So really, the way I look at the microscope is very, very different from what I was taught 25, even 30 years ago. And I think the way surgeons should look at the report is should be also focused on these things. So that made actually, that is a big difference.
Great. So Dr. Wenig, let me jump over to another topic here, and that is that how do you, before you generate a final pathology report, are you reviewing a surgeon's operative note? Do you call surgeons and say, what did you actually find in the operating room? What's your usual protocol?
So I'm frequently, almost every case, looking at the operative note, especially if there's some gray areas in trying to interpret whether there was extrathyroidal extension or not. And if need be, I will email the clinician, surgeon, and have a dialogue with that individual. So to answer your question specifically, I frequently am looking in the chart, not only in terms of operative report, but what the clinical staging was preoperatively, to see if I'm overlooking something. It takes a little bit extra time, but I think it's worth the extra effort to try to do that. I just want to ask a question to the clinicians, because Peter brought up uncertain malignant potential. I've been extremely resistant to using that interpretation. It's frequently used in Europe, I know. I remember suggesting that once to you, Mark. You looked like it was orbiting Pluto. You wanted to know if it was benign or malignant, right? So I've been resistant to using that. So if it's now more in vogue here, how do you, the clinicians, use that or interpret that? Is that acceptable to you?
Yeah, so I'm going to pass it over to my other colleagues on the clinical side. But I think the problem that we face is that while we may recognize a spectrum, it's the patient that we're sitting in front of who is challenged, and they want a binary answer. It's incredibly unsettling, I think, to have that degree of vagary. And so I think that it remains unsettling, and it's an incredibly difficult conversation to have with the ultimate end user, which is the patient. Eyal, why don't you weigh in on that, and then Mike?
So we do have experience in recent years because of the new diagnosis of NIFTP, which is pretty common. And I find patients are okay with it. So the patient comes in to learn about this long name that they saw in the pathology report, and you say it's not cancer, but it is precancerous. If we would let it stay there, it might have grown into cancer. So like taking out, I tell them, like taking out a nevus to prevent melanoma, we just took it out in time before it became cancer, but we do need to follow it. Bottom line, it's not cancer. It's good that it's outside. And I find patients are pretty comfortable with this type of explanation. What do you think, Mike?
Mike, yeah, you're used to 5-hour consultations to talk about the management of an 8-millimeter papillary. How do you deal with a more vague diagnosis than that?
So I've just accepted the vague diagnosis. Yuri's right. There's a continuum here. And you just have to honestly tell people, this is the natural history of this disease. We've intervened on it at this point. The key to clinicians is when you guys come up with these different words to use, you have to do what Zubair and the guys did with Bethesda. Tell me what's the natural history of that. If you're going to use an atypical adenoma, what's the natural history? What's the recurrence? And what I find most of the time, when I get different reports from 2 or 3 of the people on this panel, most of the time it doesn't change my management at all. That freaks patients out because one says cancer and one says adenoma. And I go, well, this doesn't make any difference to me. Lobectomy was fine. You're going to do fine here. So I kind of focus on different people look at artwork differently. But for us, is it going to change my follow-up? And so in an atypical, benign adenoma, I probably never do a thyroglobulin. You throw a little atypical in there, I might do one every few years, where I recognize we're on that border. It's going to be a low-risk tumor, right? It's not going to be anything bad. So what I try to emphasize with them is whether you called it a NIFT-P or whether you called it a minimally invasive follicular with only one capsular invasion, doesn't change my management. My management's going to stay the same. And when people understand that, and then they go, oh, okay, people are just reading this differently through the microscope. We just got to get away from knowing, and I used to tell Yuri this all the time, the reports are easy, just cancer, yes or no. That's all I need to know. I don't need your long thing. And now we just know that that's not true. So it was a discussion I had to get used to having with patients because we didn't have that before. They definitely feel unsettled, and I tell them that's okay, so do I, but we'll take a look at this over time.
Great. Yuri, I want to get a little bit further into this, what I brought up before, and it really relates to an understanding of a surgeon's operative report and understanding actions taken in the operating room, and particularly as it relates to, let's talk about one structure, which is probably the most common. When a surgeon decides that they feel the need to sacrifice the recurrent laryngeal nerve, and you're looking under the microscope, but you don't see cancer involving that nerve. How do you actually stage that? And what goes into your thought process?
If I may, I just quickly want to, for 10 seconds, stop back to the previous discussion because I think it's very important. I just want to stress that there is still a big difference between intermediate tumors and tumors that we don't know what it is. Okay. Bruce brought up question about use of terms follicular tumor of uncertain malignant potential. You see, the difference between NIFT-P or minimally invasive carcinoma, to Mike's point, is that we know how they behave. So we know this is not an uncertain malignant potential. This is a big, big difference. You see, if we look at 3 slides and one slide show maybe there is invasion, maybe there is no, and we are lazy pathologists who call it, this is a tumor of uncertain malignant potential, this is not specific borderline tumors. So get more blocks, cut deeper levels, do whatever cuts the entire block through, but find and answer the question if there is invasion or there is no invasion. Do immunostains, look for endothelial staining, and answer this question. This is very different. I in my life, practically never made diagnosis of tumor of uncertain malignant potential, but I make a lot of diagnosis of minimally invasive tumors and NIFT-P. Because this is data-driven, because we know that NIFT-P has less than 1% probability of recurrence. That's what's important for clinicians. So again, we have to draw a line between borderline entities that we know how they behave and those that we really cannot, we are limited in our diagnostic abilities.
Yeah.
Coming back to your question about recurrent laryngeal nerve, I want to say that's fortunately we don't deal with these situations very often. I don't remember last time. I mean, for a number of reasons, sometimes there is a clear-cut invasion. I honestly don't recall a situation when we saw it, we didn't see tumor in the area of recurrent laryngeal nerve and it was sacrificed. I guess what I would say, I would probably for sure would do, I would put a lot of sections through. I would cut a lot of levels through. I would really want to be sure that there is a tumor nearby or not, because I understand that there is there is a lot of not only professional but even medical legal implications if you don't study this area very carefully.
So, Margie, we've talked about this before. Tell me, how do you interpret that? I am struggling to get a nerve separated from a cancer, or I see it going into a cancer, but you don't see it under the microscope. So how do you make that call?
Right. But before I answer your question directly, Yuri, I want to say I agree very strongly with your point. It's an excellent point, and it's worth, re-emphasizing, is that, we know what NIFTP does. We know what minimally invasive follicular carcinoma does. And I also try to stay away from unknown potential, because it implies we don't know what that tumor will do. So your point is very good and worth emphasizing. So you and I have talked about, what happens when you don't see cancer and you don't see nerve. And so it's very clear. The AJCC is clear. And so the convention that we go by is, well, the surgeon actually drives the gross thyroid staging. And this is a big topic, so even if something is like apparently a T1, it may not really be a T1. So, this and many other reasons why it's really important to, have this line of communication. I have, my fellow is always checking the medical records before we sign out thyroids, and it takes time. And if she's out and if I'm busy, I may not check every single thyroid, and then it comes back to bite me. Something that I thought was a T1 is really a T3. I would only know it by communicating with the surgeon, or maybe it's somewhere in the op note, but I might not know that. So the general idea when people are doing outcomes research on thyroid is, and pardon me, AJCC staging, but we're responsible for that, we're really responsible for saying what's the real final stage. And it may not be, as we all know, what we see, only limited to what we see on the slides.
Zubair, can you weigh in on that? The surgeon sacrificed the nerve, but you just don't see cancer invading that nerve. Tell me how you stage that. What's your thought process?
I mean, so I do look at the operative notes. I still have to go by what I see. The operative notes always help me, because there's always this preamble that is written before the operative notes about the history and something that is not really in the labs or in the other. So that helps me to really guide me what I'm looking at. And I think this open discussion thing I basically have submitted all the tissue. I don't see it, and letting them know that I think is important. So if I don't see it, I'm not going to report it. But I think that open communication, because my concern is mostly because the reports now are first seen by patient, and I sometimes get a direct call from the patient so I want my report to be as clear as possible. Naturally, there's some things they will not understand, but I think sometimes we take it for granted that patients may not be that educated, but I'm very surprised at how educated they are about the terms that we use. So I think we have to be very cautious, very clear. Naturally, we're going to report what we see, but I think that open communication, and I will always say that the case was discussed with the surgeon. And regarding this, so it is in the report, and that I just didn't make it up, just didn't do it in vacuum. So, as everybody's pointing out, which I'm glad that everybody's pointing out, that they're becoming more and more cautious and they're taking everything into account. So I think that's how I handle my report. I also want to say that I have never used the term tumors of uncertain malignant potential. I made a mistake of using it in the note, saying that this tumor may be interpreted as tumors of uncertain malignant potential. And I will tell you, I got a call from the patient, from the husband, and from the son. They're saying that, what does it mean? That malignant word. So I think I will not use that word. So for me, that was a big lesson that I did. And it was buried in the note, but the patients read the whole report and they're very educated. So
Maybe, have you guys thought about changing it to a tumor of uncertain benign potential? That might be,
well, but the discussion is, and I mean, Yuri was part of it, and Ronnie was actually one of the major parts of that discussion, and everybody else is like, that term was kept because that diagnosis is mostly used in the in Europe. But if you really look at the definition of it, as Yuri was pointing out, it's more for the tumors that invasive, irregular piece of it that you cannot come to. So if you try your best, and I know some places they may not be able to submit the whole tissue and do blocks and sections to really say, but I think that was one of the major factors that we had to keep it in the WHO, because the European pathologists do use that terminology. So it has like the Bethesda, there's a British version, there's a Spanish version, there's an Italian version. So I think that's why we kept it. I mean,
I have another recommendation. Why don't we get rid of minimally invasive follicular thyroid carcinoma?
I don't think that this panel is for that, Bruce.
I know that, but just taking what you said, I mean, those tumors behave as benign tumors. There's no vascular invasion. Why are we, if I take that
Bruce,
criteria,
I know that we're using the word carcinoma, but we know, as Yuri has pointed out, that nothing is going to happen to the patient. And as long as Mike and Ashok keep on talking about this tumor, Eyal, that nothing is going to happen to the patient. I mean, I think that will be a major change. How we define this is more important, and how we relay that diagnosis is more important than, I do agree with you. Sometimes I even say, and I always say it's invading in the capsule, but it's not invading beyond it. I mean, I try my best as much as possible, but I think we kind of know that these tumors are not, and I'm hoping that in the next iteration of WHO, we may come to that level if we are still involved. I think Ronnie should talk about this. We had
before you guys keep changing names, let me put Ashok and Mark on the burner here. We all talk about reading the op report. I will tell you, I don't know how many op reports I've read. I have a really hard time interpreting what you guys did. If you know the story, you know what it is. So Ashok and then Mark, when Ashok, he sends me a note, but then we talk in the hallway and I have a really good picture about what he found. I don't get that same good picture from the op report. So Ashok and then Mark, how do you communicate that? Because we still got a time lag, right? The op report takes a few days to come out, but how do you communicate in that note? Ashok first?
Yeah, I think this is very important, and I think Mark has been working on this with many leaders in the field. You have to realize 50% of the op reports are done by the fellows. And that's the way the surgical training is. And now, with all respect to the system, more than 70% of the thyroid op reports are synoptic. Now, you can't write in the synoptic, the details, the tumor is stuck to the nerve, etc. And one of the questions Mark brought up was very interesting, that you sacrifice the nerve because the tumor is all around the nerve and you can't separate it out. Can't do an oncologically sound operation, so you sacrifice the nerve, which on final pathology, Margie says there is no tumor invading the nerve. I know that. I think the surgeon has to stand up and say, I know the tumor was not invading the nerve, but I couldn't separate or do an oncologically sound operation. And that's why I had to sacrifice the nerve. I use a simple analogy to the patients, a rotten apple. If you want to eat part of the apple, you're going to go way beyond the rotten area so that you have a clean white apple. And when I use that analogy, patients understand that, why we sacrifice the nerve. And I think if you are sacrificing a functioning nerve, it's a responsibility of the surgeon to tell the pathologist, number one, and write a note in the chart apart from the synoptic note that why I sacrifice this nerve. I couldn't have taken out the tumor in a handsome fashion without sacrificing the nerve. And that is more true in a functioning nerve. If the nerve is paralyzed pre-op, 99% the pathologist will find the invasion. But if it is functioning pre-op, they may not find, and one has to write that. To me, when the surgeon has sacrificed a functioning nerve, there is a gross extrathyroidal extension. And when the pathologist calls me, yes, I tell them there is a gross extrathyroidal extension. I just want to expand one other point. One of the questions that always comes up is the final pathology report showing minor perithyroidal adipose tissue involvement. I think that is one of the confusing part and was used by many endocrinologists as an indication for RAI. I think that is done away with the new guidelines and new staging. So minor extrathyroidal extension is a commonality. The thyroid gland thickness is only 1 centimeter or 1.5 centimeter. Your 2 centimeter tumor, it is supposed to be out of the thyroid, no doubt about that. But that's a minor, and that's the responsibility of the surgeon to tell that there is a minor involvement or a major involvement. When we talk about extrathyroidal extension, it is the responsibility of the surgeon to tell and write a note that there was gross extrathyroidal extension. And the last thing I will take only a few seconds is the final pathology report showing positive margin. The positive margin is, again, commonality in the thyroid. The tumor is on the surface of the thyroid. You paint it or ink it, it's going to be positive margin. There's no doubt about that. But the surgeon has to be able to override that pathology report and say, I took out all the gross tumor. And that's the responsibility of the surgeon.
Mike, Mike, you wrote let me just get back to this point here and try to finish this up. You wrote the AJCC staging on this with some colleagues. So tell us how we should be thinking about this as it relates to adhering to the AJCC guidelines.
So to be honest, when we put out the new edition of the AJCC guidelines, we weren't clear about this at all, and we got questions back. And so what we did to quickly answer it to say you can only upstage it if there's pathologic evidence of involvement of the structure. That, to be honest with you, did not go through a full discussion at the committee. It was something we did afterwards. So I think this particular topic, when we re-update the AJC, is going to come back. But technically, the way we have it written right now, you have to have the surgeon saying there's gross invasion, and you have to have pathology invading the structure to upstage it on AJCC. I think it'll probably stay that way, but it needs a good discussion from the committee with all the nuances you guys are talking about. But just to be transparent, we hadn't discussed that in any great deal. We needed to clarify for people because it came up really quickly afterwards. So that's why we wrote that addendum. So right now, you need invasion of the structure, and you need the surgeon to say there's gross invasion to be able to upstage it to the higher stage.
Great. So let me go to a completely non-controversial topic here of the role of frozen section in thyroid pathology here. Zubair, give us some guidance here. What guidelines should we use here for when to use frozen section?
Mark, is there anything non-controversial in thyroid?
So
only if you ask only one pathologist. If you ask one, there's nothing controversial. In a panel, different story.
So, we have our own guideline at Penn, and that is Dr. Lavolsi. So, so everybody is scared of her. So we don't do frozen section, especially. So, but I think it was a good training for surgeons that based upon cytology reporting, that was important. You know, Bethesda 4, Bethesda 5, you really are not going to actually frozen sometimes actually upstages it. These cells can look really crazy on. I do think the frozen section is more of a guide. It's like a roadmap, you know, like a lymph node versus parathyroid. What kind of other structure? If this is outside, they found this nodule, they want to make sure that it is thyroid or a parathyroid or something else. And then you can see those surprises on the frozen section. But I really don't actually, when you do frozen section, I think in most cases, it makes it actually more complicated if you are doing it on the lesional tissue. So I really don't like frozen sections. I only like frozen sections if they're really using it to guide where they are and how far they want to go, and knowing what their structure is. So, we have been pretty lucky. So we really don't.
Dr. Wenig.
Do you know this is being recorded and Dr. Livolsi is watching this?
Dr. Wenig, are there any other questions surgeons can ask that you would feel comfortable answering on frozen?
I just want to backtrack that at Moffitt, they're also scared of Dr. Livolsi, so we don't do frozen sections here either. But I guess at Mount Sinai West, the fear of Dr. Livolsi doesn't exist.
Who's Dr. Livolsi?
Because I remember doing a lot of frozens for you, Mark. So I agree with Zubair, right? You know, if there's a preoperative diagnosis of malignancy or suspicious for malignancy, you know, what's the point of doing a frozen? You're guided by that and should be doing a total thyroid, you know, and there's nothing I can add to that except for confusion. So I'm not sure that there's anything more specific. Sometimes we get lymph nodes to evaluate for metastatic tumor, but other than that, and the possibility, you know, of a higher stage like anaplastic carcinoma from a sampling perspective to you know, guide the clinicians, you know, there's limited utility for using frozen section for thyroids.
Yuri, what's your thoughts on this?
Yes, in Pittsburgh also we do very minimum, mostly parathyroid versus a lymph node. That's more common situation. I mean, some of our pathologists advocate to do touch preps, actually, you know, not even to do actually frozen sections, because on touch preps you will see nuclear features better than on the frozen sections. But overall, no. I also want to throw in that in addition to very good cytology now, many nodules come with also molecular, which gives an additional layer of information for surgeons and predicts the behavior of tumors. So I think that the current age, again, in our practice also, the role of frozen sections is really minimal.
Great. Ashok, you've written about this as a guide intraoperatively. What do you ask of Ronnie during surgery that influences your actions in the operating room?
So I think, you know, when we talk about frozen sections in the thyroid, let's divide them into two groups. One, the thyroid itself, and the others, which is I think Yuri mentioned, lymph nodes, parathyroid. So the lymph nodes and parathyroids are very good, and we get a lot of information which is very helpful to the clinicians or the surgeon. For the thyroid itself, it is very rarely helpful, because keep in mind, again, it is still a clinical judgment. And the whole idea is the pathologist told me it is cancer, I'm doing total thyroidectomy. I think it is done away with. We decide the extent of thyroidectomy based on the clinical findings and not the pathology report. The one thing that we never get on the frozen section is how much of an angio invasion is there. And that's probably the only indication where we bring back the patient for completion if there is a major angio invasion, which you're not going to see on a frozen section. The one other place where it may be of help, and Rani has helped me many times, that there is a question about medullary thyroid cancer, and I want to do a little more central compartment dissection. I'll take out the lobe, send it for frozen section, and he tells me it is definitely medullary cancer. I'll do a total thyroidectomy and central compartment dissection. The other place where it helps is suspected lymphoma. There is a big mass, and I'm not sure what is going on. I take a good biopsy, and he will tell me This looks like lymphoma. It is not just a straightforward Hashimoto. Get some more tissue. Either I will do a subtotal thyroidectomy or take out a hunk of tissue. I think that's the only other place where it helps. Otherwise, it does not help. When I was at downstate, I used to do quite few just to find out whether it is a colloid goiter or not. But again, the clinical decision making is not dependent on what the pathologist tells me on frozen section. And it's also a responsibility of the surgeon not to tell the patient, I made this decision because the pathologist told me this. I think that will be inappropriate. You make a decision, don't tell what the pathologist told me. Let them report it in the final report.
Eyal, is that characterize the relationship of the pathologist interoperatively here in Israel?
Yeah, I think it's the same. The surgeons many times use it to look at organs outside the thyroid, to see parathyroid or lymph node or something, if there's invasion or just adhesion, Hashimoto's thyroiditis and things like that. Now, I see we don't have much time, so I want to ask one question, and that's about vascular invasion in encapsulated tumors. And our pathologist, and you are already very experienced and very good thyroid pathologists, but when I see a report from someone I don't know, and they tell me no vascular invasion, I didn't find good criteria how many slides you need to do to look at the whole capsule. If there's consensus about what exactly is vascular invasion, do you need thrombus? Do you don't need thrombus? So I don't know how disseminated the knowledge is in cancer in places that are not thyroid cancer excellence centers. What do you think?
Ronnie, do you want to tackle that?
Yeah, there is no question. There is some disagreement in regard to the criteria of vascular invasion. There are some criteria that are put in the College of American Pathologists, but most of us, I think, definitely the people on the panel disagree with these criteria because there are criteria that were generated by one group, and they can risk under diagnosing vascular invasion. There are criteria that are put in the WHO that is online and in the AFIP fascicle that will come, and all this that people should use. So you will have to tell the pathologist to basically use this specific criteria versus the criteria of the College of American Pathologists. I'm very strong about it. Now, of course, as I said, these are not written in they are not absolute criteria because we have still disagreement and so forth. But it's very important that people at least because we spend our life overdiagnosing thyroid cancer, the ultimate failure will be to underdiagnose threatening malignancy. If I can just give it 2 seconds regarding what Dr. Wenig brought regarding minimally invasive follicular carcinoma. Which are, it's true, in the immense majority, they don't do anything. Now, there are cases who actually have distal metastasis with capsule invasion, but they're usually a distal metastasis at presentation. So here the issue is what if the definition of malignancy of carcinoma in thyroid tumors? What people like Mike Tuttle will accept as a risk to cause something borderline? Is it less than 1%, Michael? Is it less than 0.001%? That is the issue where that we'll be facing if we're gonna change nomenclature. Just I want to say that. Yeah.
I also quickly want to say that we actually have a working group. Ronnie participates and several others on international study on minimally invasive tumors with capsule invasion only. We have 160 cases from all over the world, and we'll be working. I don't know what the group will decide in terms of the reclassifying it, because it's also, to Ronnie's point, a very thin line. If one focus of capsule invasion is benign, what about 2? What about 3? There is also some continuum there. But definitely, we want to come with a solid data to show what is the risk of recurrence or metastasis in minimally invasive carcinomas. That study is coming.
Right. Peter, why don't you weigh in a little bit on vascular invasion here?
I mean, there's not much to say. I mean, there's everything to say, but you know, it's one of those things. Let go and let God. You know, it's quite a challenge because you know it's subjective. So you know, the objective criteria that tried to be added. Oh, you must see a tumor thrombus. I mean, all of the pathologists here will agree that that's not true. You know, and that's one publication that gets referred to now, like 20 years later. So that's the case. But the problem is that despite immunostains say, oh yes, you know, it's adjacent to a vessel, or yes, it's abutting a vessel. You know, overt wide invasion of vessels is obvious to all of us. It's these questionable ones that, you know, they're vexing to us. Now, the fortunate thing, you know, from Bruce and from Yuri is that even these ones that are questionable to us, that are challenging, biologically typically are insignificant. But we don't know. That's why I'm saying it's sort of left for a higher creator than us to figure it out. But we can only say, you know, what we see and be objective about it and straightforward, and then that's it. And it's the same thing that Mike says. Okay, now he's learning to have these hour-and-a-half long conversations about a 0.1 centimeter microcarcinoma. Then you can have this about vascular invasion because it's unclear. It's extremely unlikely to do anything unless it's overtly widely invasive. But at the same time, could it do something? Yes, but this is the same situation where I've had tumors that the entire capsule submitted. There's absolutely zero evidence of invasion, and there's been a single metastasis. I mean, again, one case. But at the same time, you know, these are the discussions you have to have with the patient. But I think the vascular invasion can be very, very subjective. And I think that if you're emotionally uncomfortable calling it, the likelihood is there's zero consequence to the patient, but you just have to be able to have that conversation.
Just one, Mark, if you allow, very quickly. In my experience, vascular invasion in terms of undercalling and overcalling is one of the most common error in thyroid pathology. We see sometimes vessels full of just a float and knife artifact, and it's called multiple foci, uterine carcinoma with multiple foci of invasion. In opposite, they don't call invasion when there is invasion. In my opinion, if you see clinically that something doesn't make sense to you, request a second opinion. Ask some pathologist who has significant experience with thyroid to look again, because number of errors with diagnosing vascular invasion or not diagnosing is very high.
So I think this brings, as we sort of wrapping this up, and I think those are really valuable words of advice here. I want to ask each one of you sees innumerable consults from the outside, and you probably see repeated errors in diagnosis here over and over and over again. I want to ask you for a closing word of advice to clinicians out in the community who don't have the benefit of working with one of you directly. What word of advice would you give them in questioning pathology reports when they come in? Margie, do you want to go ahead and start with that?
Sure. So, you know, I can speak for myself in that I try to keep the wording of my reports very uniform, so that when I write something in a report that is not my usual language, that means we have to talk. And so I guess, you know, when we're talking about the community surgeon, the community pathologist, you know, the message would be, you know, open lines of communication, ask a lot of questions, ask about irregularities so ask about irregularities in a particular case. So for instance, the case that when we had this last seminar, when we talked about the case that taught me the most, in my opinion, it was the surgeon looking at a report, which was probably very correct, and probably there was a real gap, and they never spoke because the patient was never followed again, you know, and that would have changed the whole timeline for that patient. So what I'd say is look for irregularities and talk to your pathologist.
Zubair, what's your advice to the clinician in the community? Just give us a brief word of advice here.
I think diagnosis is important, but I will say that they should also read the gross description. How much of a tumor was submitted? Because if it's saying that it's an adenoma and only like 3 sections were submitted, there is a problem. So I think reading the whole report, including the gross, to me, that is of utmost importance.
Great. Unfortunately, we are up against the 9 o'clock hour, and as always, I'm going to give Mike Tuttle the final word here. Mike, give me your summary statement. What have you learned in terms of delving into the psyche of this group of world-class pathologists?
I've learned they're as troubled as what I had anticipated, and you should only ask one of them at a time. No, I think it's just an honest description of the situation we face. It's not black and white, it's a continuum. And the studies like Yuri's leading of this very defined group, what are the outcome? The next defined group, what are the outcome? That's what we need as clinicians. So we understand those descriptions. You did it for us in Bethesda. We now understand those. You've done it with the molecular testing. So in these specific anatomic path, very clean sets, know what those clinical outcomes are, and then we can use them clinically. So that's the bottom line to me.
Awesome. Everyone, thank you so much. Thanks to all of our listeners, and really appreciate all of your input today. Everybody stay safe, and look forward to seeing you next week here. Thanks so much.
Thank you.
Thank you, Mark.
Bye.
Bye.